Number. Okay, we are recording now again. Hello, everyone. Welcome. Today I have my third discussion, and I will always show the number. I mean, as long as my fingers are not enough. I don't know. So, yeah, as you can see, I'm through the wind. I don't know whether you also have this idiom in English. So it can be a little bit embarrassing right now, but I will hand into Ravi.
You know, Shema, I think you've taught us much, but I'm glad that I've taught you one thing, which is the importance of saying hello more than one time on VMR. If you just say hello, it doesn't feel like VMR. I was really happy to see you say hello 3 times, which is also the same number that you've discussed. Yeah, Shema's in lukewarm seat today, ready to mesmerize us all. And we have an all-star crew of CP solvers folks who are also hanging out here today. And as always, we'll poke the crowd to see if you all have a short and sweet case for 30-minute VMR today. So I'll mute for 10 to 15 seconds. It can be any case. I misdiagnosing cystitis and cellulitis on VMR. So if you have a case, please, please, please. Ooh, Kiara, tell us more.
So that yeah, it's today and tomorrow are two celebration day. I don't know why two, but today is the Independence Day, and tomorrow is going to be like I'm not that well. I don't well understand why there are today Independence Day, but it's a very, very happy day for Peru, and yeah.
That's incredible. How is Independence Day typically celebrated in Peru? What usually happens?
So, Peru is very well known because there are many holidays. So
yeah, good.
Yeah, many holidays. I mean, Potato Day, something like that. Really.
Easy.
So we used to the 28th. It's usually a common day to go eating or something. Something Peruvian food, and the next day is just like a one more holiday day, so people rest and that kind of things. So also tomorrow is my granny's birthday, so I'm more excited about that.
That's a bigger holiday than Independence Day. I completely agree.
Yeah.
Amazing. Well, thank you for sharing that. I hope your Independence Day goes very, very well today.
Yeah.
All right, Leah, maybe we'll lean on your on the case that you have in store for us and learn from that. How does that sound? Perfect. All right, Shema, let's rock and roll.
Okay, so this is a case report that I found, and the chief complaint, well, at first it's a 20-year-old male that had a 4-day history of malaise, fever, nausea, and headache.
Okay, shall I start? Okay, so we have a 20-year-old male with 4-day history of fever, nausea, and headache. The first thing that comes into my mind, again, we have headache. And as we know, the key question is a primary or secondary. And here we have fever as a systemic symptom, which is already giving me some warning signs. And for headache, I also have the Snoop mnemonic to see what is like dangerous. Like if we think of the Snoop mnemonic says like, do we have systemic symptoms? Is there any neurologic symptoms? How is the onset? Is it something like a thunderclap headache? And also the older age, like here he is young, so less concerning, because as we always learn, there's this mnemonic, the older the colder, so he's young, so I would expect him to have fever if there's any kind of infection. And also the P was whether the headache is positional. Do we have any kind of papal edema that lets us think of something like an increased intracranial pressure? And also, is there something like a pulsatile tinnitus? And also for fever, again, we have this IMATE mnemonic as we always go through, and also thinking of nausea. So the combination of fever, headache, nausea makes me again think, is there something like a meningitis? Because like nausea could be a sign of increased intracranial pressure. Yeah, but sometimes we can also have some kind of nausea due to, if we think I mean, it's not vomiting, but sometimes I think, I don't know, maybe some irritation of the area postrema or something like, I think some inflammation going on within the rump encephalon, like thinking of something like listeria, but he's 20 years old. And I just try to think of more common bugs if I think of meningitis, as I learned from the last meningitis case that I had. So think of common bugs like something like strep pneumonia. Also think of Neisseria meningitidis, and also think of again listeria, especially in older people. And what else? Yeah, I will remember it. I will hand into Robbie.
Shema, can I ask if I told you this person had infectious mononucleosis as their final diagnosis, you think that would be a good explanation for their symptoms? Like if there turns out to be EBV, acute EBV in a 28-year-old man, would you believe it? Would you be happy with that, you think?
No, not actually. I mean,
why not?
I mean, for EBV causing that kind of systemic symptom, like, I mean, headache for sure, but also, oh wait, I mean, I mean, I don't know whether you're tricking me, because I would expect more. I mean, I have to say,
I think people should watch what happened in your mind. Your mind is so coached to make sure you don't miss any bad diagnosis that you're prioritizing meningitis here. But if you slow down and think about it, EBV, influenza, COVID, acute HIV are very fair game for causing malaise, fever, nausea, and headache.
that's true.
So the truth is, the more common answer in this situation will be that you have a systemic viral infection. The less common but more morbid or lethal answer is that this patient has meningitis. Now, your discussion highlights how important it is to track morbidity first. Nobody cares what's common initially. You have to prioritize and ask the question, does this need an LP? But the harder thing, the thing that we should practice in the CP Solvers VMR is to take it to the next level and ask ourselves, well, what features of this case will push us towards morbidity even more? And I will arm you that I would stop the history right now in real life and ask two key questions before I move on. And those key questions are, it's right here. Those key questions are, do you have photophobia? Imagine if this story is, hey, doctor, I have fever, headache, nausea, vomiting, and photophobia. EBV, probably not. Similarly, if there's prominent neck stiffness, the calculus changes tremendously. So in this case, if I'm seeing this patient, I think the next key questions are very specific signs for meningitis, photophobia, and neck stiffness. If they are absent, that doesn't rule out meningitis, but if they are present, I would get an LP right away. If they're not present, then I think you have some time. Why? You can diagnose things at the rate that they are coming. And if this patient has 4-day history, you can take 4 hours to figure it out. If this patient has a 1-day history so sick that they're coming right now, you probably have less time. So the fact that it's been going on for 4 days gives you some leeway, but that leeway vanishes if the patient has more specific signs for meningitis. So big takeaway, when you have a febrile headache, the probability is systemic viral infection, the morbidity is meningitis. The tiebreakers are photophobia and neck stiffness. They're very helpful questions to ask in this space. All right, Leah, let's get some more information.
Okay, so next will be past medical history, social history. So this is a patient who has a known HIV infection, and he was diagnosed 2 years prior. And he's currently on ART. I'll post the names in the chat just because they're long, but there is no history of AIDS. And he has a CD4 count currently at 611, which is within the normal range that was given. And the viral load is 20 copies. He also has a history of secondary syphilis, which was appropriately treated, and a history of being hepatitis B surface antibody positive. For the social history, so he's Japanese, no travel history, and he engages sexually with other men, so MSM. And I would stop here, and the next would be the physical examination.
Go for
So,
it. Shreya.
okay, so actually the thing is, when I see the past medical history of an HIV infection that was diagnosed 2 years ago, the key question that comes into my mind, I mean, when he started the anti-retroviral therapy, is how was the CD4 count, and did he have any kind of, what kind of infection did he have? Because I was also thinking of something like, I mean, thinking of some complications of HIV, there's this iris, as we know, sometimes if you have some underlying cryptococcal infection, or if you had a very low CD4 count or some underlying tuberculosis infection, and then you treat it with with the antiretroviral therapy, you can get like 2 weeks or even 2 years after the therapy, this iris as a complication. There was one thing that comes into my mind as a complication, and also seeing, I mean, yes, he's for the MSM, also thinking like, I don't know whether he's using some protection, like, as we know, HIV isn't the only sexual transmitted disease. We don't know whether he's always using condoms. And then for the secondary syphilis, I heard that it was treated. Am I right, Leah? Okay. And for the hepatitis B, I mean, I could imagine like if the hepatitis B was progressing into, I'm not sure, like some kind of cirrhosis, or I mean, we don't know how long he has been positive, whether this could lead to, I mean, some immunocompromised state that could make him more susceptible to another infection. So I feel like this person is immunocompromised, so I wouldn't exclude fungal infections, but still, as we learned, systemic viral infections are more common. But I have to say, I would give the mic to Robbie.
I know, I think that is brilliant. I hear you emphasizing the syphilis. I hear you emphasizing the role of HIV in this case. And I think both of them are such powerful pieces of medical history. And, the fact that his CD4 count is high at over 600 certainly eliminates a lot of infections, including cryptococcus. But I think there's one thing to ask yourself is, what infections are patients with HIV at higher risk for with a normal CD4 count? And the answer is sexually transmitted infections. So this could certainly be syphilitic meningoencephalitis or meningitis for sure, as you said. And then there's a short list of infections that patients with HIV continue to acquire, even if they have a normal CD4 count. And that list includes a much higher rate of disseminated strep pneumo. So strep pneumo, bacteremia, and meningitis is still much higher, even with normal CD4 count. And the other meningitic disease that's more common in patients with HIV, especially in men who have sex with men, is Neisseria meningitidis. You'll see that has a much higher rate. So those two infections you should think about in this case, but also that if there's TB exposure, the rates of TB are still high even with a normal CD4 count. So there's a small list of infections that are in CD4 count independent, and then there's a small risk of sexually transmitted infections. But we're focusing on meningeal causes. He could have a run-of-the-mill viral infections, but his residence in Japan is also intriguing. And as a short list of infections, you should know that Japanese encephalitis is totally fair game in this situation, as one of the most common causes of encephalitis in East Asia, including in Japan. But you have to step back and say, how do we know this is not COVID? How do we know this is not influenza? And when you hear of a febrile systemic syndrome in a man who had sex with other men, you have to consider monkeypox. So could this be monkeypox before the rash emerges is another important consideration. How could he have a systemic illness right now that could hurt him a lot? And the answer could probably be a rickettsial organism. So there's a lot of rickettsia in Japan. But long story short, Shema, I think you're absolutely right. We have to analyze this case around the HIV and around the syphilis, and also sprinkle in the fact that this person is in Japan, and the unique epidemiology of Japan will influence a lot. But also the fact that there's a global pandemic of COVID and monkeypox can't be ignored. All right, Leah, back to you.
Great discussion. So for the physical examination, he was ill appearing. He was anecteric. His blood pressure was 110/65, and his heart rate was 85 beats per minute. Respiratory rate was 14, and his temperature was 37.4 degrees Celsius. And his physical examination revealed tenderness in the right upper quadrant and hepatomegaly. And that's all the information I have for physical examination. I would stop here. And then maybe also you could say which labs you would like to see in this patient.
So seeing the tenderness in the right upper quadrant and also the hepatomegaly. So I'm asking myself the question, could there be something like, I mean, the basic things like just from the clinical reasoning, right upper quadrant pain, lets me think, is it the liver or is there something going on with the gallbladder, something like a cholecystitis? Or sometimes we also have to think of retroperitoneal organs, but seeing that he has hepatitis B positive and also the hepatomegaly, that makes me prioritize more the liver. So maybe some kind of, thinking of hepatitis. It could be the issue, and also the hepatomegaly could be due to his underlying hepatitis infection. But still, thinking of organomegaly, I always think like just from the clinical reasoning, is there some, we have this mnemonic with water, red blood cells, or something like any kind of molecules, something like an infiltration if we think of water. So due to portal hypertension, due to the something like the liver issue, or if it's red blood cell, thinking of something like a hemolysis, or also when we think of white blood cells, is there any kind of malignancy, or thinking of lymphoma, also in the infiltrative issue, amyloid, sarcoid, and so on and so on. But yeah, so now, just now, I would still prioritize the issue, maybe that he is immunocompromised due to also the underlying ongoing liver disease that he has. But I have to say, like, his vitals are completely normal. He doesn't have any kind of fever. So basically, I really need help, Robbie.
I don't know if I agree with that. I think you absolutely nailed it. You're saying in some ways that his exam is more reassuring than what his history sounds like, and I completely agree with that. And I think you shared a great overview of the causes of hepatomegaly. You clearly have looked in studies at those CP solver schema, and maybe because you translated so many of them into German that you know them so well. And I have nothing to add. I think that the reason you might feel like you need help is because the case inherently hasn't guided you much further. You have to be careful that the liver may simply be a reflection of the hepatitis infection and have nothing to do with the case, or it may tell you that their patient has hepatitis or cholecystitis or cholangitis. So I think thinking of that carefully as you did is very wise. I really appreciate that. The only contribution I will have in this aliquot is to really, really thank our guests who've turned their videos on. So David, Arush, and Ria, it really, really makes a huge difference to see your faces. So thank you all for doing that. And that's the only thing I can add to Seamus' wonderful discussion. Leah, in terms of the initial labs that you asked for, I think I would start basic just to try to get an inventory of all the organs. So I think a CBC, renal panel, liver enzymes, and a lactate, looking for thrombocytopenia, leukopenia, leukocytosis, lymphocytosis. So I would start there before I get fancy smancy. Yeah. Mike, to you.
So for the labs, we have hemoglobin of 16, white blood cell count of 3,200. The platelet count was 111,000. The creatinine was normal. The LDH was elevated with around 4,500. We had total bilirubin, which was elevated with 2.1, with direct being 1.4. The AST was 5,400. The ALT was 4,200. And alk phos was 394. with INR, which is the last one I'll give now, is 1.4. And you can tell me if you want more labs or if this is good for now.
So, basically looking at into the hematology, so we see actually he has bicytopenia and a normal hemoglobin. And I have to say the combination of bicytopenia and elevated transaminases also lets me think of what I learned, this tick-borne mediated infections, because there was also some kind of discussion going on. I mean, he is Japanese. I don't know where he is living. I mean, if he lived in the States, I would also consider things like ehrlichiosis or anaplasmosis, but I'm still not sure. And also, if you look into the labs, it's rather concerning for a hepatocellular pattern because AST is over ALT, and the alphos, yeah, it's not that high in contrast to the transaminases, and the very high LDH, like in the differential. The first thing that I always do is to exclude hemolysis. But seeing that the hemoglobin is normal lets me brings my shift now more thinking of, could there be some underlying malignancy that he has? So something like lymphoma or leukemia, but sometimes also any kind of infection of the liver or infarction, also from the lung, could make such high LDH. And we see that the direct bilirubin is high, so we are with the underlying hepatitis infection that explains it. Yeah, and I also have to say, seeing the low platelets, it's like the first rule that I always learn is like, I would have thought of ruling out schistocytes, but seeing the normal hemoglobin and no signs of hemolysis brings my shift now away. But I would now give the mic to Robbie.
No, I think Shema, you did. Let me just show people what you did, and I'll do it more slowly because you're doing it in real time. So essentially, I hear you making the argument that it's all about the liver. So we have a patient who said he had fever, headache, nausea, who was then found to have AST, ALT really high, and LDH that's really high, leukopenia and thrombocytopenia. And you eloquently basically said nothing else matters except the AST and ALT. And let me just explain why. So the source of the LDH, which is also an intracellular enzyme here, is the liver. The LDH can come from muscle, can come from liver, and can come from cancer. But here you have such high liver injury, so the LDH is irrelevant. It's basically telling you that you have marked hepatocellular injury. So delete that. Headache, oh my God, acute liver injury of this high. Of course, the headache is coming from that because you can get some mild cerebral edema. So nobody cares about the headache anymore. Nausea, liver injury. Fever just tells you that you're probably dealing with an inflammatory cause of liver disease. The leukopenia and thrombocytopenia may be a clue as to what's causing the hepatitis, but may simply reflect the fact that there is mild portal hypertension. So you may use the leukopenia and thrombocytopenia as a mild modifier, but the question is, what are the most common causes of an AST, ALT this high? This case is really that. And the focus initially is always on infections and drugs as the cause of liver injury this high. And the infections are probably best divided into the professional infections, those that specialize in destroying the liver, and then the kind of like casual infections. So the professional infections are the hepatitis viruses, A, B, C, D, and E. And here you already know that he has hepatitis B. So could he have reactivation of his hepatitis B or progression of his hepatitis B or hepatitis D superinfection, all of which are possible. But just because he has hepatitis D doesn't mean that he's not vulnerable to another infection. And the other infections that do this are yellow fever, which he cannot have because yellow fever does not exist in Asia. It's purely a sub-Saharan Africa and South American disease. Or does he have another virus like dengue, which is very, very possible? Or more importantly, does he have herpes virus hepatitis? And the clue to the herpes virus hepatitis is the fact that he has HIV. So that'd be something I would think about. But at the end of the day, I think what he needs is NAC or non-acetyl. Wow, I'm forgetting what NAC stands for. Let me know in the chat what NAC stands for. But I think you probably would and acetylcysteine. Thank you so much, David. Yeah, I think you probably need to treat him for hepatitis B empirically while you do the diagnostic tests around that. Any clarifying thoughts or questions come up for you, Shema, now that you've had more time to think about this whopping result?
No, I have to say I'm just so impressed how much I learned through. I mean, within so less minutes. So, I mean, the only thing that I would add is like I was also again going on through the acute liver injury schema as we were talking about the hepatitis viruses, and I was like, I remember, I mean, in the chat there were also again talking about the herpes viruses, and I remember. I mean, what was coming from my mind again, like also never exclude EBV. Like I remember like EBV can also affect the blood count, and I mean it can also cause as we know something like HLH. But here I still don't know whether how his ferritin is, but as we know, the criteria for HLH consider us to think of next to high ferritin also, wait, let me check. Yeah, low fibrinogen, very high triglycerides. So I don't know whether we have some kind of labs like this, but he has bicytopenia. So I would still think of that. Yeah. But yeah, you can carry on.
Great. Well, I hope I'll give you some answers for some of the questions you had. They tested for EBV and also CMV, and both IgM were negative. And I see that IgG was slightly positive for CMV and also slightly positive for EBV. Then they also thought of retesting whether he had like an acute syphilis infection, and that was negative. They also tested hepatitis C antibodies, which were negative. And for hepatitis B, they tested the antigen and the antibody. The antigen was negative. The antibody, as mentioned in the history, was positive. And then they also did an imaging, which was a CT scan of the abdomen without contrast, which just revealed the splenomegaly. And there will be one more test that will reveal the diagnosis.
Professor Shema.
Oh God. So now seeing that he is, I mean, he is IgG positive for CMV and for EBV. What would be important for me is to also make some CPR to see how the viral load actually is. Mm-hmm. And also I have to say, for the hepatitis B panel, I only have the German things in my mind, like when I think about how it is. So before I say something embarrassing, I would lead the hepatitis B panel to you, Rabi. And and also now seeing the splenomegaly, I mean, the combination of, again, like the same differential for splenomegaly, I mean, I really prioritize infection now with the whole labs. And for splenomegaly, I mean, the important question to me would be also, what kind of splenomegaly is it? Is it massive splenomegaly or something that is or not massive? Because I recently had some discussion ongoing, like we only have a smart differential list if we think of massive splenomegaly. Like, I don't know whether it's important now because the time is very short, but when I think of massive splenomegaly, it's more like going off myeloproliferative or something like malaria or leishmaniosis or something like this. But if it's just something like this, I would still prioritize EBV, CMV. So I still don't rule it out. So PCR count would be very important to me, but I would give the mic to Rabi, I have to say.
No, I think you're absolutely right, Shema. I think whenever you're in the world of fever, liver, and spleen, the focus is on infection, and those come in three flavors. The mononucleosis infections, which you said, or which are totally better tested by PCR. And then there's the tick-borne infections, and the best example of those are the arthropod-borne infections. And the best example of those are the rickettsial organisms, but there are many others too. And then the final ones are the granulomatous infections like TB. And the granulomatous infections aren't known for their ability to cause marked liver injury. So the question here is this a mononucleosis infection or a tick-borne infection? And the truth is, the real question you're faced with is, should you empirically treat this patient with doxycycline for the small possibility that the arthropod-borne infection they have is a rickettsia? Not all arthropod-borne infections are treated with doxycycline. Lyme disease, for example, is treated with ceftriaxone, and many arthropod infections like West Nile, dengue, don't have a specific treatment. So all those are still very possible. But now with the splenomegaly, you have to ask yourself, is this a very aggressive lymphoma? And the reason that deserves some attention is because this is a patient with HIV who is at risk of a liquid malignancy regardless of their CD4 count. And so I think that what would I do in real life is I would look for more specific tests for mononucleosis. I think that the relative preservation of the hemoglobin should make you wonder about arboviruses like dengue. You know, it is a febrile headachy syndrome. And also think about rickettsial organisms. And there's a very specific rickettsial organism in Japan, aptly named Rickettsia japonicii. So I honestly would probably give him doxycycline. I would probably test for the fancy smancy arboviruses. And in the back of my mind, I'm like, if that doesn't go anywhere, then I think there's nothing incompatible with lymphoma in this case, and maybe even lymphoma complicated by HLH, as you were alluding to. Yeah, I don't think I'm confident of what the answer is, but I think the path is outlined. It's mono infections, arboviral infections, and if those are negative, then hunt for lymphoma. Anything you want to add or reflect on before we hear from Leah about what happened?
So I have to say I'm very, very amazed by the whole discussion. I have to say it was very, very tough case, I have to say, but I mean, I know I will again learn so much from it, and I am very thankful for Leah that she presented the case to us, and I'm so excited to learn something new and get some brain gains. Thanks again.
Well, thank you for your discussion. I will reveal the final test. And it was actually a diagnosis that was mentioned already with the main causes of hepatitis. And they did a test for hepatitis A IgM, which came back positive. And so the final diagnosis for this patient was actually an acute hepatitis A infection. And the reason I thought this was such, like, I learned a lot from it because I actually looked for this case report when I saw a doctor order hepatitis A antibody because he was looking for sexually transmitted diseases. And for me, I always associated hepatitis A with just contaminated water, food, travel history, and didn't actually know that's also, it can be like a sexually transmitted diseases, especially like engaging like with oral sex, as is more common or as is a common risk factor for hepatitis A is a common risk factor for MSM. That is one of the main teaching points that I took away, and it's important not to forget that, and also don't see the vaccination just as a prevention for people who travel, but also for populations more susceptible, such as MSM. Exactly. So actually the final diagnosis for this case was hepatitis A infection.
Wow. Shema, your thoughts?
I have to say I'm very amazed. Like I really didn't expect it. As you say, I always associated acute hepatitis A only with some contaminated water, but I also have to add one thing. Just I remember seeing one kid in the pediatric station also with acute hepatitis A, and it wasn't that this child traveled. It happened in Germany, and I was also so mesmerized because I never associated like an acute hepatitis A infection going on here. So this is also some reflection about thank you so much, Leah. I really learned so much new again. And again, also thank you to Ravi for giving me the opportunity to discuss with him, and also the whole crowd here discussing in the chat. The chat was again on fire. I took so much from it, and yes, I hope for many more discussions to come.
Oh, Shema, your humility knows no bounds. And I think the biggest thing that stuck with me is just how you rose up to the challenge of the fact that this case is inherently very intimidating, right? Like you have a very sick patient with almost acute liver failure who has so many distracting features, their HIV diagnosis, their residence in Japan, and using it as an opportunity to learn and strengthen your diagnostic skills is incredible. And I think the case inherently just goes to show you how you have to be careful in trying to rush to an answer. And I think that what you really ought to try to do is just have a sequence of diagnostic steps. And the sequence of diagnostic steps in this case, I would say acute liver injury, infection, toxin. Within infection, the professional infections get priority, and those are all hepatitis A through M, and then the less common infections, which again are the herpes viruses, the tick-borne viruses, and the herpes viruses include EBV and CMV. So if you stay rooted to that, your chances of getting the diagnosis wrong are lower. And so here you like stay anchored towards, hey, I haven't ruled out all the hepatitis infections, and here you are with Hep A. And I had learned this association that Leah just talked about, but I completely forgot it because on average, only about 20% of what you learn you'll remember. So I really appreciate you for giving us the practice to go through that journey, but also reinforcing a really important learning point. So thank you. Yeah, I think there's a lot to learn in this case, but I'm just honestly so intrigued and also inspired by the incredible growth mindset that our case presenter and your story of bringing this case, Leah, and our facilitator, Shema, have. Really cool to see. All right, we're a little over time, but we got to learn again. And remember, 20% retention rate. So Ariel and Madalena, we're going to increase that rate with having us go through the teaching points again.
Shall I do it?
Yes, go for it.
Thank you, Madalena, for carrying me through the teaching points. This is such a great case. I learned a lot. So I'll try to be quick. We have a young patient with fever, headache, and nausea. And I liked how Shema approached this first to rule out most life-threatening causes. So we immediately go to like life-threatening causes of fever and headache, like meningitis. And the nausea could be anything, stimulating the chemoreceptor zone. So our question first was whether this patient needs an LP right away. We talked about whether the patient has photophobia or neck stiffness. The absence of these symptoms may not completely rule out meningitis, but worth asking. And then we learned that the patient is HIV positive with a normal CD4 count. And then we talked about diseases that HIV positive patients with, MSM patients with a normal CD4 can get. That includes other sexually transmitted diseases, disseminated strep pneumo, Neisseria, and there are, of course, other viral infections in our time, like COVID, flu, monkeypox. And then with physical examination and lab work, we learned that the patient has tenderness in the right upper quadrant, which localize to either the liver, the gallbladder, or retroperitoneal organs. And then the patient has hepatomegaly. We talked about whether that could be caused by his hepatitis B, history of hepatitis B infection, or it could be due to some infiltrative diseases such as lymphoma, amyloidosis, and it could be congestion of the blood. We learned that the patient has bicytopenia with very severely elevated transaminases, which anchors us to some infections like tick-borne diseases, anaplasmosis or ehrlichiosis. It could be HLH. with the elevated LDH, together with the severely elevated AST, we localize that to the liver. So it can be malignancy, liver infections, infarction, much less likely hemolysis due to is normal hemoglobin. And then we talked about common causes of high AST and ALT. So that's usually either infection or toxin. I like Robbie's approach of professional infections, which is hepatitis A, B, C, D, E. It could be like a reactivation of his historical hepatitis B or some other hepatitis infection, super infection on hepatitis B, which turns out to be the case. And then there are casual infections like yellow fever, but it's only endemic to sub-Saharan Africa and South America. Doesn't really fit to this patient. Could be herpes virus like EBV or CMV. And then there are always drugs, but not really relevant. In this case, we talked about with such elevated AST and ALT, we probably want to treat first while working on our further diagnosis. With imaging finding, so we have fever, liver pathology, and splenomegaly. We further rule it down to some mononucleus infections, arthropod-borne infections like arbol infections or rickettsia from tick-borne diseases. We talked about whether we can empirically treat with doxycycline. There could be granulomatous infections like TB, and Robbie reminds us that lymphoma can fit all these. And the final diagnosis is acute hepatitis A infection.
Oh my gosh, absolutely superb. I love how you narrated that. You know, you like didn't just outline your teaching points, you cohesively strung them together as we went through the case. I absolutely love that. Thank you so much.
Thank you.
All right, y'all. Well, we'll hope to see you tomorrow. Just as an FYI for those of you here and listening on YouTube, we're starting RLR 1 hour earlier than usual tomorrow. And we really hope to see you there. Bye now.